Good afternoon. I'm Catherine Santoro, Director of Programming at the National Institute for Healthcare Management Foundation. On behalf of NIHCM, thank you for joining us today for this important discussion on critical health issues facing current and formerly incarcerated people and solutions to improving their health. Incarceration exacerbates existing health conditions for the millions of Americans in prison and jail. Incarceration is a public health crisis that disproportionately impacts Black and Brown men and women. Incarcerated people experience higher rates of communicable diseases, chronic conditions, and mental health conditions. These health challenges continue when people return to their communities after incarceration. This reentry population experiences high rates of mental health issues, suicide, substance use disorders, disabilities, and physical disorders. Strengthening healthcare for incarcerated people and during reentry can reduce these disparities. Today, we will hear from a prestigious panel of experts to learn more about health during and after incarceration and discuss strategies to support individuals and improve their health. Before we hear from them, I want to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene today's event. You can find biographical information for our speakers along with today's agenda and copies of their slides on our website. We also invite you to join our conversation on Twitter using the hashtag #ReentryHealth. I am now pleased to introduce our first speaker, Dr. Lauren Brinkley-Rubinstein, Associate Professor and Director of the Re-envisioning Health and Justice Lab in the Department of Population Health Sciences at Duke University. She is a national expert in examining how the criminal legal system impacts people, families, and communities. We're so honored to have her with us today.
Thank you, Catherine. I appreciate the invitation, and I'm excited to spend the next 15 minutes or so really setting the stage for our other presenters. Okay, so what I'm going to do is really talk about incarceration as a determinant of both individual and population health. There are my credentials again. I want to put forth a roadmap to give you a sense of what I'll discuss in the next few minutes. First, I'll talk about the history or context of incarceration in this country and be really explicit by what I mean when I talk about the criminal legal system or incarceration. And then I'll go from there and speak about the intersection of incarceration and health. So this is a chart that many of you may have seen before. There are a couple of important things that I want to point out. If we go all the way back to the beginning of this chart in the 1880s, even then the rate of incarceration in this country was far outpaced that of other countries. So we've always had this elevated rate of incarceration. If we look to the late 70s, the early 80s, big changes in the number of people who are incarcerated in this country, and that's largely due to the war on drugs, changes in sentencing policies, harsher sentences. If we look to the future, if we look to now, this is a kind of dated chart, but the trends remain that incarceration in many ways, the rate here has plateaued, still much, much higher than the rate of incarceration in almost any other country. And I want to be explicit about what I'm talking about when I talk about incarceration. There are state prisons that account for about 1 million people who are incarcerated. These are run by states. There's one in every single state. They tend to hold people who are sentenced and are serving longer sentences, usually about a year or longer. About 600,000 people in any given year are in local jails. Almost every county has one. Important things to remember about jails are that one, they have a very short average length of stay, about 72 hours on average. So people really churn in and out of jails. If we look at any given year, about 11 million people in total go in and out of our jail system. That's a massive number of people that are exposed to jail conditions. Smaller slice of the proportion is federal systems, and we see federal systems in almost every state. Those are people who are convicted of federal crimes, much smaller than state or local jails. Then we have about 4 million people who are on community supervision, so under some type of carceral control, but in the community, and this can be post-release supervision or parole or probation. And it's impossible to have this discussion without focusing in on racial inequities. I'm using the phrase mass incarceration here, but in fact, a lot of people really don't like that phrase because it denotes that incarceration equally impacts all segments of society, and that's not true. People prefer to use the phrase hyper-incarceration because that more explicitly tells us that incarceration impacts certain communities more than others. If we look at this graphic from the Prison Policy Initiative, we can see that Black people, Latinx people, and Native people have greater proportion of people in prisons and jails as compared to the proportion of the general population. It's important to note that this doesn't have anything to do with crime. If we take the example of drug use, lots and lots of studies have shown that, in fact, often white people use more drugs than these other groups. It really is where police are at, where they're deployed, where resources are allocated. And it has to do with the legacies of slavery to Jim Crow to mass incarceration that has set up the current paradigm that creates racial inequities in the system itself. I'm trained as a community psychologist, so there are people on this call who work with me who are really over the fact that I'm always having some kind of social ecological model on the screen, but here it is again. And I think this is a nice way for us to think about all the different levels of impacts that incarceration or other facets of the criminal legal system can have on people. If we start with individuals, that's easy. It's individual health behaviors. It can be individual health outcomes. I'll talk about those on the next slide. But I think it's important to also talk about the other levels that incarceration can impact. So one is incarceration impacts families, relationships, friends, social networks, measures of social support. It also impacts organizations. This is a little bit more of an abstract concept, but in my lab, we like to talk about this concept of carceral creep. And it really is this creeping of carceral logic into other social institutions in society. A couple of examples might be school systems that in more recent years have leaned into punitive solutions to address social problems, the presence of things like school resource officers. We see it manifesting in healthcare. So the idea of the non-compliant patient or punitiveness when patients don't comply with doctor's orders. There's also an emerging body of literature that takes it beyond the individual, that looks at population health and the impacts or the relationship between community health outcomes and density of incarceration. I'll also talk about that on the next slide. And lastly, I just want to talk a little bit about public policy, because the carceral system or the experience of incarceration can be quite different depending on where you might be incarcerated. And those of us that do this work often say, you've been in one jail, you've been in one jail. It's true that carceral systems do have some similarities across systems, across facilities, but they're all really different. And the impacts of incarceration, the collateral consequences or the restriction of rights that people might experience post-release is really determined by local policy. And so being incarcerated in one county could be very different to the next, and it can certainly be different from one state to the next. And it certainly looks different now, depending, compared to like what it might have looked at like several years ago. So it's also varying across time. I want to spend the rest of my time really talking about disparities in health or the certain conditions that are overrepresented among people who are incarcerated. And it's important to note that if we take any health outcome, we could probably map it on in the same way, because there are extreme disparities in almost every condition that you can think of when it comes to the incarcerated population. On average, people who are incarcerated have at least 2 chronic conditions, so a big overrepresentation of chronic illness in general in this population. I'll focus in a little bit on some specific outcomes though. So first, thinking about infectious diseases. Many studies have looked at the disproportionate rate of HIV and has shown that it is 2 to 7 times higher. Additionally, about 17% of all people living with HIV in the US pass through some carceral facility in any given year. If we take a look at hepatitis C, we see similar disproportionality. The rate is about 8 to 21 times higher than the general population. And this goes on and on with other sexually transmitted infections. We see similar patterns. Not on this graphic is COVID-19. This is an older graphic. Our group has done a lot of work focusing in on disparities relevant to testing, treatment, diagnosis, and mortality relevant to COVID-19. We found that the rate of COVID-19 tends to be about 5 times higher than the general population, and the age-adjusted death rate is about 3 times higher. This links back to the overrepresentation of chronic illness, so people who are incarcerated tended to suffer more severely from COVID-19. Also, on average, before the pandemic, prisons were overcrowded. And so you have overcrowded facilities, very little ability to engage in things like social distancing, really created a perfect storm for transmission of COVID-19. When it comes to substance use or mental health outcomes, we also see disparities here. So if you see that bar chart here, big differences in the number or the rate or the proportion of people who have substance use disorders who are in carceral facilities compared to the general population. And that is in part because illicit substance use can lead to incarceration. So there's, it's hard to disentangle that. We also see when it comes to serious mental illness in jails, big disproportionate rates. And I think many of us have heard that jails in this country have become the largest healthcare provider for mental health. And that is really because of gaps in access to mental health in the community itself. And we see this play out in prisons as well. There's also an increased risk of mortality post-release, and it runs the gamut of causes. So if we look at all-cause mortality, disproportionate rates, if we look at specific things, there are some things that are important to note. So if we look at that immediate post-release period, there's been a lot of work actually looking at the 2-week post-release period that has shown that overdose is a leading cause of death. And that really links back to this disproportionate rate of substance use disorders among people who are incarcerated. And then I want to focus just finally on community outcomes. So I'm going to highlight 2 studies here because this takes us away from the individual and back to the population health perspective. One recent study examined rates of sexually transmitted infections as a function of jail and prison incarceration rates. They found that the documented differences in chlamydia and gonorrhea incidence between counties was partially attributable to those differences in jail and prison rates. So we see this association between higher rates of incarceration and higher rates of various STIs. Similarly, another study that was published in 2021 found a strong association between jail incarceration and also mortality from infectious diseases, chronic lower respiratory disease, drug use, and suicide. And so all of this is really to set the stage for the presentations that are coming up next and to give a little bit of insight into the impact of incarceration, how it can impact people, various health outcomes, impacts on families, and also whole communities. And that's it for me, and I look forward to answering questions at the end of the presentation. Thank you.
Thank you so much for giving us that overview of the history of incarceration and the impact on health outcomes. Next, we will hear from Vikki Wachino, Executive Director of the Health and Reentry Project, an initiative to promote public health and public safety that she launched in February 2022 in partnership with the Council on Criminal Justice and Waxman Strategies. Vikki is a principal of Viaduct Consulting, where she advises mission-driven healthcare organizations to advance the health of people and communities. Vikki also served as Deputy Administrator of the Centers for Medicare and Medicaid Services from 2015 to 2017, And under her leadership at CMS, she oversaw the implementation of ACA expansions, Medicaid and children's health insurance program, and groundbreaking policies to expand services for people with substance use disorders. We're so grateful she is with us today to share her perspective and some new work.
Catherine, thanks so much, and thanks to the NIHCM Foundation for highlighting this critical but sometimes under-recognized topic. It's very valuable to be with you all here today. I'm having a slight problem advancing my slides. Let me try that again. Here we go. Now we're in business. So you've heard already from Dr. Brinkley-Rubinstein a bit about the impact of incarceration on people's health. What I'd like to cover with you today is building on that, talking about the challenges that the health system faces in meeting the needs of people who've experienced incarceration, and then talking about some of the very promising policy changes that are under active discussion now to start changing Medicaid's role to better meet the needs of people as they're leaving. And I'd also like to share with you the work of my Health and Reentry project, and specifically the roadmap that the HARP created with stakeholder input that's designed to lay the groundwork for a vision of implementing these new Medicaid policy changes in a way that advances the health and well-being of people leaving incarceration and engages people across the health and criminal justice sectors, as well as people with direct experience of incarceration, in paving the way to these new changes. As I go through each of my slides, I'll pull out a few key pieces of information and leave the rest to you to absorb over the course of the conversation. I'd be happy to answer questions about them at the end. So as you saw from Lauren's slide, that had the bullseye with the different concentric circles, there are many ways of thinking about the impact of incarceration in the criminal justice system. Today, with this audience, I wanted to talk about the impact that incarceration and the way in which we respond to it as health system leaders is affecting the health system specifically. You've heard about the elevated rates of death, including deaths from opioid overdoses, the high rates of public health issues, the high rates of physical and chronic conditions in prisons and jails. And when you think about that from a health system perspective and the community health system that serves people before they're incarcerated and after incarcerated, it's clear that the way in which we're responding to the health needs of people as they re-enter is not sufficiently moving the needle, and is also holding the health system back from some commonly shared goals. So as health system leaders, we think about how do we increase life expectancy? How do we improve public health? How do we advance equity? How do we address national crises of mental health and substance use disorder? And how do we avoid unnecessary use of high-cost settings like emergency rooms? All of those goals are challenged by the data that you see in the slide and that you saw from Lauren a few minutes ago. As you've heard, many millions of people experience either prison or jail each year. And as you've also heard, many of them are disproportionately Black and people of color. In addition, incarceration is highly correlated with poverty. So I invite you to consider that the population that's entering prison and jail is disproportionately of color and disproportionately poor. As you've heard, people who are incarcerated have higher rates of physical health conditions, including both chronic and infectious diseases, and very high rates of mental health and substance use disorders. Yet at release, although some people successfully reintegrate into the community, we see very high death rates from a multitude of causes, but particularly opioid overdose deaths. And you've also already heard about some of the impact that release strategies are having on families and communities. And they're also holding back some key public safety goals. But we may be at a turning point in terms of policy, and specifically developing reentry policy that can better meet the needs of people as they leave incarceration. Historically, there has been no systematic approach to meeting people's needs at reentry. If you were to canvass the reentry landscape, you would see that there are a few bright spots, but no far-reaching approach. And as you've already heard, most correctional health services are financed at the state and local level. Most services are provided at those levels, and they're provided independent of the community healthcare system. As many health leaders and criminal justice leaders have thought about how to start building towards a stronger approach, it has been natural to turn towards Medicaid. Because Medicaid, as the dominant insurer of the low-income population in the United States, has significant reach into the population of people who've experienced the justice system. Medicaid, like private insurance and Medicare, has historically played very little role in financing correctional health care services. Medicaid has been prohibited from paying from everything except for community hospital stays since it was created in 1965. And over the past several years, and in particular, since the coverage expansions of the Affordable Care Act have translated into record numbers of people in the United States having access to affordable health coverage, some states and local governments have made progress connecting people to Medicaid services after they're released. And now we have a cadre of policymakers who are interested in creating greater continuity of services for people as they're released by allowing Medicaid to start for the first time covering some services before people leave prison and jail. And the idea is that by doing that, Medicaid can provide a bridge to community health care services when people are released and better meet the multitude of health needs that people who've experienced incarceration experience. These changes could take place either nationally through Congress or on a state-specific basis through administrative action by the administration, and I'll spend just a moment on each. The federal legislative pathway, there have been a few different types of proposals to change Medicaid's role at reentry. The one that has advanced the furthest is the Medicaid Reentry Act, which was introduced on a bipartisan basis in both houses and would require Medicaid across the country to cover services in the 30 days prior to release. It's passed the House 3 times. It is currently in the Senate and remains in the mix for a potential year-end legislative package. In the meantime, not waiting for Congress, 11 states have approached the Biden administration with proposals to allow Medicaid to cover in their states services at reentry prior to release. 11 states so far have submitted reentry waiver proposals to CMS. Waivers are tools that have long existed in the Medicaid program to pilot new approaches. And although the specifics of the waivers vary, they tend to focus on providing a subset of high needs people who are leaving the justice system with a subset of services. Generally, they focus on services like care management and connecting people to medication. But in a few cases, states have proposed to provide more comprehensive benefits in the period prior to release. So recognizing that there has been over the past 2 to 3 years renewed interest and even policy momentum around the idea of changing Medicaid's role at reentry, I was lucky to partner with the Council on Criminal Justice and Waxman Strategies to create earlier this year the Health and Reentry Project. And the goal of that project is really to identify, if we're going to allow Medicaid to start covering the services, how do we break this ground? We pulled this project together in recognition that to really successfully implement the changes, we needed input from health system leaders, from criminal justice leaders, from social justice leaders, and from people who've experienced direct incarceration. Over the course of the year, we've engaged more than 70 stakeholders in these conversations, and our work has been guided by a fantastic advisory committee of cross-sector leaders whose engagement and interest has been critical as we've moved these issues forward. Our synthesis of stakeholder feedback was released in July and is called Redesigning Reentry. I want to highlight 3 major elements of redesigning reentry, and I'll spend a minute on each of them in my remaining time. We established guiding principles, high-level principles for how we can execute these changes in such a way that makes a maximum impact for people who've experienced incarceration. We identified the outlines of a new care model that can support people reentering. And finally, we identified 7 essential actions for policymakers who are changing policy and implementing new policies to consider. Our guiding principles focus on strengthening continuity of care, but not just that, doing it in such a way that there's an explicit goal of helping people after incarceration return to their families and communities healthy and whole. Those words, healthy and whole, were a North Star established by one of our advisory committee members, Topeka Sam of Ladies at Hope Ministries. And as soon as she said it, it got immediate reaction from our stakeholders as a fantastic North Star. Some of the keys to helping people return to communities healthy and whole is advancing access to evidence-based clinical services at reentry, but also, and our stakeholders were very clear about this, thinking about the larger array of community services that needs to be in place, but too often isn't, that can help people have their health and behavioral health needs met before they ever experience incarceration, and ideally would help them avoid incarceration, and then also making sure those community services are available at reentry. The care model we outline is focused on primary care, but primary care with a strong connection and integration to behavioral health services, a clear focus on active patient engagement, a degree of navigation, so helping an individual navigate a system, because historically, people leaving incarceration have been left to navigate systems on their own. In many cases, people will need trauma-informed approaches, and of course, recognizing that health is not the only need that someone has when they leave incarceration, helping people access both health and social supports. And finally, as I said, we identified some key actions for policymakers, and I'll highlight just a few of them here. Aligning healthcare services that Medicaid is going to cover with the standards that pertain in the community. And doing that requires an investment in systems and infrastructure. There's very little infrastructure in place in most places in the country to share information and data about a person before and after they're released. And those types of investments will be foundational. And then finally, cross-sector collaboration. It was clear, although we had a strong group of committed leaders who joined us in our stakeholder engagement, that was really just the beginning. And the health and the criminal justice systems need to foster greater understanding of each other, speak the same language, and develop common goals for advancing the health of people who have experienced incarceration. And that along with that, having community providers, social providers, and perhaps most critically, people who have direct experience of incarceration should all be at the table to navigate and implement these changes. I'd like to end by thanking my partners, the 70 stakeholders who engaged with us so actively, and my 4 philanthropic partners, the RX Foundation, California Healthcare Foundation, Commonwealth Fund, and the Schusterman Family Foundation. And I'll end by saying the reentry work of HARP is not done. We want to make this reentry roadmap a reality. And if and when these policy changes are made by the federal government and states, we would welcome and look forward to the input of the people on this webinar today on how we can help carry those changes out in partnership with you. There are resources available to get more detail on any of this. And thank you all, and thank you, Catherine. I'll turn it right back to you.
Thank you so much for highlighting the importance of Medicaid for the reentry population and for sharing your work on the HEART project. Our final speaker will be Dr. Divya Venkat. She is the Inclusion Health Track Director at Rethinking, Incarceration, and Empowering Recovery Clinic in the Allegheny Health Network. At the Post-incarceration clinic, Dr. Venkat works on transitioning patients out of incarceration while focusing on their health and social determinants of health. She's also the medical director of the Prevention Point Pittsburgh Mobile Medical Unit, and her work focuses on the integration of harm reduction and low barrier access into healthcare settings. And we are so happy to have her with us today. Dr. Venkat?
All right, I think I have control of the screen. It's so nice to talk to you all today. I'll be building on what my previous presenters spoke about, which is really the idea of creating a model that helps people re-enter into society after incarceration. So I'll be talking about our model called the Rethinking, Incarceration, and Empowering Recovery Clinic, or the RIVER Clinic for short. So my objectives today are, number one, to describe a post-incarceration care model. 2, to outline the CIH River Clinic, and 3, to demonstrate the impact of our model. So just like everyone has kind of talked about already, why is the post-incarceration care model important? When we build these types of models, it's important to acknowledge 3 things. One is that there is a gap that exists between carceral settings and civilian life. 2 is that we need to create an infrastructure that ensures the continuity of care between complex settings, carceral settings, and outside of these carceral settings. And lastly, to provide support to address the social determinants of incarceration. Like the previous presenters have mentioned, incarceration is so much more than healthcare. It often involves things like access to education, access to a job, housing, healthcare, insurance, and really just going back to a previous environment where someone may have been incarcerated. So what is a post-incarceration care model? In many of these models, patients are referred directly from carceral settings to a post-incarceration clinic. Typically, prior medical records are shared between the carceral setting and the clinic in a HIPAA-compliant method. Post-incarceration care then focuses on acute and chronic medical problems, connectivity within societies, and collaboration with local organizations to improve health and wellness outcomes. This is just a typical flow that might happen within a post-incarceration care model. So someone is released from incarceration, and through a direct referral to the clinic, contact with the clinic is made. Many of these clinics have access to behavioral health clinicians, a social worker, a healthcare provider, community health workers, and nurse navigators. I want to highlight one post-incarceration care model that has really done an excellent job demonstrating their success and the importance of this model. This is called the Transitions Clinic. They were started, I believe, out of UCSF and are at Yale and many other places. But what I really like about this diagram is kind of what all of our missions are. Is number one is we need to build capacity for team-based patient-centered care. In all of these models, the most important thing is that we're putting our patient or our client right at the center of our services. It's crucial to hire and integrate community health workers into these models. People who have had a history of incarceration or who even understand the neighborhoods from which our patients are coming from. We need to leverage systems and services that exist within the healthcare system that we exist in. Community partners are critical to making sure that our patients can navigate through healthcare and just life after incarceration. In their model of success, what they've seen is multiple things. Some of the important things that I think really count towards our clinic are highlighted here. One is that in the Transitions Clinic out of San Francisco, people were less likely to visit the emergency department and had 50% fewer emergency department visits. This is a really, really awesome bargaining chip within a healthcare system because it decreases ER utilization and healthcare spending. $912 were spent less per year in healthcare cost utilization. More than half of the participants had at least 2 primary care visits after release and engagement within the program. Additionally, this model reduced illicit drug use and overdose risk, criminal behavior, recidivism, and most importantly, mortality. Again, these models exist not just to help improve someone's life after incarceration, but to help our clients live, which has been really highlighted during the COVID-19 pandemic. So now I'll talk a little bit about what the CIH River Clinic is all about. So these are our keys to success. So the CIH River Clinic is a part of Allegheny Health Network in Pittsburgh, Pennsylvania. We're also part of a greater organization called the Center for Inclusion Health, which really focuses on traditionally excluded populations. So these are 3 feeder systems and part of the ecosystem that we exist in. So the Center for Inclusion Health is extremely embedded within the community organizations of Pittsburgh. Because of that, it helped us a lot get in touch with other organizations and really find support within our community. Additionally, our health network has a contract with the Allegheny County Jail. We provide some of the healthcare providers within the jail. When we wanted to make this clinic, it was extremely important that we got the Allegheny County Jail on board with us. This often meant multiple phone calls per week, emails, trying to figure out exactly how we could get a referral system in process and support the Allegheny County Jail, especially during the COVID-19 pandemic. Again, like I highlighted, one of the more important parts of our clinic is our community-based model. We really believe in outreach within the community and engaging the people around us to ensure the success of our clients. We also really care about a warm handoff. So like I mentioned, the healthcare providers within the jail also are a part of Allegheny Health Network. We've worked with Allegheny County Jail to ensure a HIPAA-compliant process in order to get patient referrals. When patients are in the jail and when they come out of the jail, we ensure that patients have given us like a written consent so we can talk about their healthcare amongst multiple providers. So what are our clinic goals and why did we create this? What we really cared about is that all these patients would come out of the jail and had no access to healthcare. There was nowhere for people to go to get almost like a warm security blanket around them or a safety net when they were trying to reintegrate into society. So one of our first goals was to increase access to health insurance and social services. We care about providing comprehensive care to recently incarcerated individuals who face multiple social determinants of health issues. We also treat a variety of healthcare conditions, including diabetes, substance use disorders, hepatitis C, and behavioral health. Our goal is to alleviate the social determinants of health by engaging with an in-clinic social worker and a community health worker. And our long-term goal is to transition patients to long-term primary care providers after engagement within our clinic. This is a really busy slide, but it's just to show you the flow of how our clinic model works. So the discharge and release team at the jail will actually notify us when a patient is about to be released or has already been released. Our social worker and community health workers will then contact the patient within 24 hours of release. This is really critical. As many of the previous presentations highlighted the data around post-incarceration care, within those first 2 weeks is really when our patients are at highest risk for overdose. Being in Pittsburgh, Pennsylvania, opioids have really hit our community. And so it's really important that we engage with patients right away and provide low barrier care. Once our social worker or community health worker has been able to connect with a patient, they get an immediate connection to a healthcare provider. And during that time, we often prescribe medication for opioid use disorder. Prior to coming to the appointment, there are multiple touch points by the team members. Our team is on it. They're constantly calling patients, texting them, trying to figure out exactly what they need in order to be successful in their lives. The patient then arrives to our appointment. During this time, a healthcare provider will complete their initial appointment assessment for things like chronic conditions and medication needs. But frankly, I think most of our patients come because of the rest of our team. The social worker and community health workers really work towards helping patients reintegrate. They'll do things like social determinants of health screening needs. They'll ensure that people have transportation. We work pretty intensely with our criminal justice system to advocate for patients to stay out of incarceration. So this is our clinic structure. We have 2 physicians, a nurse practitioner, and a pharmacist. And together we address things like medications for opioid use disorder, hepatitis C, and really just a low barrier model of care. Our nurse navigator focuses on medical management within the clinic. Our community health worker visits people actually within ACJ so that she can start establishing a rapport with patients immediately. Oftentimes, exiting incarceration can be quite complicated and really just difficult. And so by having someone who's already seen someone within the Allegheny County Jail, though a person is often more likely to reach out to us because they know that warm face. She also works very closely with community-based organizations to ensure the optimal community engagement on release. Our social worker works very closely with drug and alcohol programs to ensure that patient outcomes have been improved with substance use disorders. She also works collaboratively with housing teams to improve access to safety and often provides things like brief intervention for our patients. Our patient care navigator ensures quick access to health insurance and benefits on release. Most of our patients, their Medicaid product has been turned off or has been, as they say, I guess like put on hold on release, but our patients don't have a way of actually signing up for healthcare again. So we ensure that that is turned on quickly, and she works very closely with our health insurances around here to do that. She also establishes continuity of care plans for our patients after they've completed time with us at the River Clinic. We also have a psychiatrist that's been funded by a grant, and she focuses on the effective access to care by regular screenings with things like the PHQ-9 and PTSD screenings. What I really wanted to highlight, though, is that we're much more than a clinic. Our whole clinic model is really based on this concept of outreach. Most of the week, our team is actually not even in a clinical setting. One day per week, 2 half days actually, the team is parked literally outside of the jail, and we're just welcoming people who have been released from jail. We do a number of things. We help people get bus tickets at that point. We see if people have medication needs. We help people get into shelters that are available throughout the city. We also park in different parts of the city to see if we can find people who just need help. Most recently, we parked at a soup kitchen where a lot of our patients and clients actually go to, and we just reach out to try to find them. One of our biggest barriers is actually most of our clients don't have cell phones, and so that requires a lot of innovative thinking, and we've done that by really going into the community and immersing ourselves in what our patients may be experiencing. When we hired the people in our clinic, we ensured that we hired people who are from the neighborhoods that we were serving, and that has really served us because the people that are working with us know our patients the best and actually can guide how we're designing the clinic every step of the way. We also go within Allegheny County Jail. We have our community health worker and our social worker physically go inside the jail, meet patients regularly. Being that it is a jail, a lot of our patients do end up being reincarcerated. And so having our community health worker and our social worker go back in helps patients realize that we're always there for them. So the outcomes that we always have looked at are things like reducing hospitalizations, treating and eradicating hepatitis C, reducing opioid overdoses, and increasing retention in medications for opioid use disorder. Ultimately, we'd like to reduce recidivism and also show reduction in the social determinants of health needs. We started our clinic in June of 2021, and we've had over 400 referrals from Allegheny County Jail. We've actually engaged with 60% or more of those referrals, either by a phone call or finding them within the community. In this moment, we have 50 active patients. Over 100 people have completed care with us and transitioned into their community. This means that we've made a warm handoff to a primary care physician, a treatment provider of any sort, or even just other case management services. We've actually reduced rates of return to use and reduced rates of recidivism by engaging patients in rehabilitative programs. We advocate within a lot of the court systems to have patients, instead of going back to jail, to actually go into treatment. And we work with patients while they're in treatment to make sure that they stay engaged. 12 patients have completed treatment for hepatitis C and achieved SCR. Some of these patients have been actively using and sometimes don't even come to clinic, but we figure out a way to get them their medications. And of the patients that we've engaged with, only one has overdosed within 2 weeks of being released from jail. This is a drastic decrease from the numbers that we know exist. That's all that I have about our clinic. I'm looking forward to answering any of your questions, but if you have any questions outside of that, this is my email address. Feel free to email me.
Great. Thank you so much, Dr. Venkat, for sharing the work of the River Clinic and your care model. We'd like to use the remaining time for Q&A with our audience. Please continue to submit your questions. I'll invite our panelists to come back on video and come off of mute. So a first question, we had a lot of comments. People were so interested in learning about the clinic in Pittsburgh, as well as some of the projects, potential projects that Vikki mentioned with the Medicaid waivers. Can you talk a little bit about the range of post-incarceration models and services that are existing across the country, and sort of how can this change so people can receive necessary services? Maybe Dr. Venkat, you could talk a little bit more about how you were able to get it, off the ground and what that meant in terms of collaboration. And then Vikki, maybe a little bit about, some of the potential Medicaid waiver projects.
Sure. So when we, the first time I ever actually even heard about this type of model was when I went to a conference, and I had heard Dr. Emily Wang talk about their clinic, the Transitions Health Network. And I was really fascinated by this idea of how do we get people out of incarceration but actually continue their care. So there's many types of models that exist. Our model is really centered on community engagement. What I've seen, I do a lot of addiction medicine. A lot of our patients are entering communities where it's so tough to go back. They're often entering the same neighborhood, the same house that they were first incarcerated in. And that can be really traumatizing for a lot of our patients. On top of that, it's really difficult to kind of stay out of jail when those may be neighborhoods where there are more police officers, or you do have existing warrants. So we work really hard with the community partners that we've made to try to figure out ways that we can reduce that type of recidivism and make it a little bit less difficult for our patients to go back. That has really just been an effort by our community health workers. We really care about elevating the voices of people who have existed in these communities before and will exist after us, frankly. Our community health workers actually go to the neighborhoods and find different community organizations that we should be partnering with. They literally park next to our patients' houses and ask, where would you go if you needed help today? And I think that's really been a key to success for us. We also, work within a health network, and we try really hard to advocate for our patients within that health network. We work with Highmark. We work with a lot of funders close to us, and we make sure that their voices are heard. We work to try to get Medicaid turned on as quickly as possible. And one of our community health workers always says that she's going to go to the senators and let them know that Medicaid should always be on and not something that's turned off during incarceration. Not sure how possible that is, but those are the people that we've hired. So.
Thanks so much, Dr. Venkat, for starting with that. There's so much about your model that I think is promising and that people could really learn from. Catherine, with respect to the Medicaid policy changes that are under consideration through waivers, I'll call a couple of things out. First, if you were to look across the 11 states at what's being proposed, most states are focusing on how do we reach people in that time period, which could range from 30 to 90 days, depending on the state's proposal, to start engaging with them, to prepare them for release. That could look something like the model that Dr. Venkat describes of community health workers going into facilities. I know in California, which is one of the states that have proposed a waiver, they're looking at having an interaction with an enhanced case manager that gets to know the beneficiary and their health needs prior to release. And I would say across the 11 states, the tendency is to that model of case management. How do you connect someone to medications, including medications for opioid use disorder, so that they're leaving the prison or jail with medications in hand whenever possible. But that's speaking to the average across the states. There are exceptions. Both Vermont and Utah have proposed to go far beyond that by having Medicaid cover all of the same services that are covered for people who live in the community. And Kentucky, their waiver focuses specifically on substance use disorder. There's a history of Kentucky of close collaboration between their health and criminal justice sectors, and I think that their waiver proposal really reflects a shared commitment across sectors to trying to leverage Medicaid in a correctional environment to move the needle on opioid use disorder. The other thing I will say, although there's these state-specific proposals, CMS, which is the federal agency that will negotiate and approve these waivers, and I think those conversations are underway right now, is also required by Congress to issue waiver guidance for all states. That was a requirement that Congress imposed in the Support Act of 2018. And I think having these 11 states make proposals to CMS really gives CMS a nice range of approaches to consider as they write national policy. And so all states will be able to look to that national policy when it's released for what it is that the federal government is interested in supporting through Medicaid.
Great.
If I could take just one more minute, Divya has mentioned twice this issue of connecting people to Medicaid eligibility as they're released. And I will say that you do not need a waiver for that. That could be done now. And the issues there are really operational and systems issues. But there are models for how to do that. Ohio, for example, has created a specific eligibility unit so that people who are leaving incarceration can connect to that unit and try to get their Medicaid coverage turned on quickly. Ohio also used peer supports in their prison system that starts to interact with beneficiaries well before release to talk about health coverage and what it can mean in terms of access to services. Also New Mexico, some places in New Mexico have done a really strong job of connecting people to coverage. They've had some application assisters working in the prisons and jails to help people enroll in Medicaid coverage and to try to keep it as active as possible on release. So it's a work in progress in many places, but there are some real bright spots in terms of making coverage as continuous as possible for people.
Great. We had several questions about community health workers and if there's specific trainings, are they part of a broader network? And then also, one more here. I guess if communities have a community health worker network in place, how can they best connect with a program like this in their community?
The community health worker model is not new. You know, it's like existed in countries for long before America adopted it. In Pennsylvania, we do have a community health worker network where they actually do undergo formal training, which I think has been really awesome for our two community health workers. Both of them, I think one of them did not complete college, one of them did complete college, but the fact that we were able to give them this like extra title and this extra certification to highlight their lived experience has been really awesome for them, and they're very excited about it. So when we were hiring, both of them had found other jobs, I think, within the health network, but we did hire another peer that came from the community. And usually, I think the best way to go about it is to actually just ask people within the community themselves. A lot of our patients are actually really interested in doing community health worker work after we can figure out what's going on with incarceration and what their legal woes are at this point. But it's really, I think, important to actually hire within the community. A lot of communities, they may not have like an actual network that we would think of. It's not like a job posting, right? But I think if you go to a lot of the big community centers, you'll find people. I think really common places are places like YMCAs are a really great place to kind of meet people and try to figure out like who are the leaders in their community and what do they want to say. We have a lot of churches around here where there are a lot of people who are interested in things like community health worker models. Again, I cannot highlight more how important it is to have community health workers, because I think that's how we're really able to deliver effective care. I don't think my knowledge of any community is even close to what people who have lived experience have and how we are able to navigate things so effectively.
Great, thank you. We had a few questions about access to maternal health care during, pregnant and postpartum period during incarceration, and also just access to screening services. Are there any examples or, strategies you could share for people that are interested in expanding work in that area? I don't know, Lauren, if you know any research on.
Yeah, it's a great question. These questions come up a lot, and the answer is often not very satisfactory because every place is very different. Every system is really different. So when it comes to screenings, there are some places that have really robust screening in place, lots of resources that might be devoted to things like preventative care, and then in other places, just absolutely no resources at all. So, there are, I would say it's probably more standard to have screenings for things like HIV. And then usually the medical intake process is, it can happen in 2 steps. So right when you come in, someone might ask, do you have any conditions? Are you taking any medications? And then, 2 weeks to a month down the road, you might have a more formal assessment by a healthcare provider that's doing more in-depth screening or asking about conditions that might exist. Again, that looks really different across different systems. And when it comes to maternal health, I think in some ways that's a very similar answer exists. I think the community standard of care is often minimally met, at least in carceral facilities, but there's actually a lot of opacity around how those things operationalized, or very little measurement around how it actually works.
Thank you.
Catherine, if I could just say how welcome this question is, even though I cannot point to a lot of specific models. I think, as someone who's concerned with health policy, I've seen so much momentum and energy over the past 2 years around maternal health and infant health, and the focus on new moms, and in particular Black moms. But what I haven't seen follow on that is the recognition that about the role that incarceration is playing for those new moms, and how challenging it is to be pregnant or to give birth in a carceral facility, and the impact that that has on the health of the mom, the ability of the mom and the infant to attach, and on the mental health and well-being of both. So I will say a challenge to the field of people who've gathered here today is, as we think about Medicaid and reentry, we should also think about new Medicaid policies, which more than half of states have taken up to keep Medicaid postpartum coverage active for a year, and the intersection between those two, and how we can really, identify ways that for these low-income moms who've experienced incarceration, recognize that there's a real opportunity here to better meet their needs and the needs of their children and families.
Great. Thank you. We are almost out of time, and there's so many great questions, so we will try to share these with our speakers if they're able to take some of them. For maybe a wrap-up question, if you could just offer us a final thought on what do you feel is the greatest barrier, but also kind of the maybe low-hanging fruit or advice for next steps that folks in our audience could consider for advancing work on this topic.
I'm happy to go first and just say that I think often there's a real siloing of resources and also consideration of the health of people who are incarcerated. We saw, especially in the context of the COVID-19 pandemic, that a lot of public health departments at the state or local level really didn't have relationships with their local jails or their prisons. And so something that I like to say all the time is that there really needs to be better collaboration and better partnership between different public health entities and jails and prisons at the local and the state and the federal level.
Thank you.
I totally agree with that. And additionally, it's very hard to build those relationships during a crisis. And so I think and hope that one thing that we can accomplish in this time period where we're looking at these issues more closely as a health system than we have before is like, can we build partnerships that endure and that are there when we want to address Hep C, that are there when we want to address COVID, that are there when we need to address the overdose epidemic. So definite +1 to Lauren's comments. And the last thing I'll say is I just wanted to pull 3 things that Dr. Venkat said out from her presentation as things that I think people could learn from nationally. One is the ability to access data and access information. Allegheny County is really unique in its integrated data system, and investments in those types of systems really underpin care delivery and give us the ability to see what's happening prior to release and after release. The second is the degree of outreach in the community that Dr. Venkat described. And along with that, the third is the emphasis on people from the community. I really think that a community health focus is the key to success here. It's something that's not always the larger US health system's greatest strength. But if we're really going to think about moving the needle on a population that has significant needs and has experienced significant disadvantage, I think that community health focus is worth considering.
I obviously echo what everyone said. I think one of the major things that we had talked about in this, which kind of mentioned, is Medicaid, and I think just how it's standardized across the country. One thing that we struggle with consistently is that for some reason, only behavioral health is turned on immediately after release and not medical, which is a huge issue for us because we obviously are prescribing medications for things like opioid use disorder. But it sounds like some states are really doing a great job at that. And so I wish there's a way for us to standardize how that's done in every state. So that way this population wouldn't be at the mercy of when a state would want to turn something on or how it's turned on. And I think the last thing is, I'm guessing there's a variety of people on this call, but I think just recognizing that this population is not, I think one thing I hear from my patients a lot is that they're described as criminals, right? They're described as people who are undeserving. There's a lot of guilt that goes into whatever's happened. And I think that we just remember that everyone that we see is a person, right? And everyone has different life circumstances that have led to where they are today. I don't know if I would be in a different place if my life had been different. And I got lucky, right? And I think that remembering that everyone that we interface with has a story, they have struggles, and that our job is to really listen to them. Just because someone comes in and they have a quote unquote record, or they've had some life circumstances led them to be where they are, that doesn't mean that we shouldn't care for them. And I think that's really low hanging fruit, is just treating each other kindly and with respect, and knowing that we all come from difficult backgrounds sometimes, and our job in healthcare is to make it better for everyone.
Thank you for that, and thank you all for the work that you're doing to advance this, addressing this topic, and thank you for being with us and sharing your perspectives. Thank you to our audience for joining the discussion and all of your great questions. Your feedback is important to us. Please take a moment to complete a brief survey on your screen. The slides are available on our website, and we'll also be making a recording of this available. So we hope that you can check that out, as well as some of NIHCM's additional resources and some resources from the speakers as well on our website. So thank you all so much for joining us today.